Hi, I hope you are well. This podcast is a place for people to share personal and professional perspectives, talk openly, and ask questions. From serious to silly to sublime, it's all about communication and connection. Always coming from a place of kindness and curiosity, we talk about shared humanity, discuss ideas, and highlight people creating a better world. We've got to keep learning, keep growing, keep being. I'm Melissa Beek, and this is Beek on Being. Today's episode is Beek on Being Fertile. So many factors go into a person's decision to reproduce, when to reproduce, as well as the factors that affect their ability to reproduce, such as age, genetic issues, and disease. People may delay having children and choose egg retrieval as an option because they may have health issues they need to prioritize. They may delay for preventative measures because of genetic issues. They may want to wait until they have more financial security, focusing on career first and family second, their age and amount of egg production, or even because egg retrieval is an option now when maybe previously it wasn't an option at all. There are so many personal and medical reasons. Today we will talk about fertility, the population experiencing fertility issues, the factors and decisions that go into choosing egg retrieval, and what the process of egg retrieval entails. We have two incredible board-certified physicians in studio today to talk about it all. So please introduce yourselves and tell our listeners a little bit about you.
Okay, great. Hi, I'm Dr. Rebecca Karsenti. I'm a Miami native. I went to Palmetto High School here in Miami and then went to Duke University for college. I then came back to Miami for medical school and did my training in Boston at Tufts University and OBGYN. I am a general obstetrician gynecologist, which means I do a lot of things for women. I serve all ages. I love seeing teenage girls and being their first introduction often to medicine outside of the pediatrician's office. And I go up to older age as well. I'm doing a lot of menopause treatment, a lot of talk about perimenopause, and lots of infertility and fertility in general. I love all things women's health and really excited to be here and talk about fertility today.
Excited to have you on.
And I'm Armando Hernandez-Rey. I'm a board-certified OBGYN and reproductive endocrinologist and fertility specialist. I mainly focus on infertility, basically taking everything in comprehensively and what's relating to the infertility, as well as the endocrinologic aspects of it, which are just basically dealing with hormones. I'm a professor at both medical schools, and I have the residents in the medical schools that do rotations with me and shadow me. And I'm, I think kind of a dinosaur in the fact that I'm one of the few infertility specialists today that does quite a bit of surgery, both minimally invasive robotic surgery and open procedures, anything that's relating to the care of an infertility patient. And happy to be here, and I really thank you for the invitation to contribute to this incredible podcast.
Oh, thank you. I'm honored to have you both. I know you spoke a little bit about your population. Can you tell us a little bit about your population too that you serve?
Basically, I see patients from puberty to menopause.
Got it.
Today, actually, coincidentally, I saw a patient from Israel who has complete androgen insensitivity. So that means that she's a pseudo-hermaphrodite and was born as an XY, but was born with a vagina. And, that creates a lot of complexity, both from a health standpoint as well as obviously from a reproductive standpoint, because she has no uterus or ovaries. So it's the gamut of patients.
You get it all.
Yeah. But obviously the focus is infertility, or
right,
as it relates. Today's world is different than what it was when I was a fellow. And we're seeing patients up to, their early 50s using donor egg and or surrogacy and even donor sperm.
Amazing.
As it relates to their particular issues. So, yeah.
That's awesome. How did you both get into this profession?
Please.
Okay, I can start. So my dad is an OBGYN, so I watched for years as women would come up to us everywhere and, oh, Dr. Strasberg, you're so amazing. You delivered my child. You mean so much to me. And I loved the connection that he had with his patients. But at the time, I thought that I would be a pediatrician because I loved the idea of continuity of care, but I wasn't sure that I wanted to do OBGYN. But then when I went through medical school, I realized I loved it. The day I delivered my first baby, I was like, this is amazing, of course. And I haven't looked back. I actually thought I might do infertility at some point, but the way life took me, I ended up staying and doing general obstetrics and gynecology. I delivered babies for about 17 years, which was amazing. And then now I've been focusing more on women's health.
Got it.
So I wanted to be an orthopedic surgeon.
Really?
And,
I didn't expect that.
yeah, I went to medical school. I was sure that I was going to be the Dolphins team doctor, and I was going to be the guy that was going to run out to the field. And get the wounded.
Right.
But I unfortunately had a really bad fracture when I was in high school, and I got sort of PTSD. But I was always inclined to take more of the surgical approach, and I went into OBGYN to be a GYN oncologist and pivoted shortly thereafter to infertility because it's just what an amazing field, and the amazing things that you can do for patients, and it's so cutting edge. And when 22 years ago when I was a fellow, things have changed
Completely different.
Dramatically.
Yeah.
And so I no looking back, I couldn't have made a better choice for myself, and extremely happy. And
I'm sure both of your patients are beyond thrilled.
And I can attest to her dad, who was my professor and who was an amazing mentor for me.
Yeah. Oh, he's amazing.
Thank you.
Got a fan club here, so I love it. When we talk about fertility, we're talking about a person's biological ability to reproduce, to make healthy eggs, and then, of course, sperm, so it can be fertilized egg, can be implanted and developed. When we talk about infertility and needing egg retrieval, it's because this conception isn't occurring. So many factors are involved in affecting our reproductive systems: disorders, disease, age-related, societal, or environmental factors. Is there a specific medical definition on infertility as far as time period of trying or a person's age more specifically?
Yeah, I mean, the classic definition is anybody less than 35.
Less than 35.
Should, if trying for over a year, then should look to her OBGYN for guidance, and if not, infertility specialist.
Okay.
And after the age of 35, it's 6 months. That's a very old, very dated definition. Right. And today's world, the generations today that are looking to conceive, for the most part, are very much instant gratification. Nothing wrong with that. I am too. And I think people have a timeline, particularly now that women are waiting longer because they're pursuing careers that take a little bit of more time.
Right.
They're professionals. They want to take their, enjoy their lives post graduate school or whatever endeavor they're pursuing. But they are very much aware, as opposed to 22 or 25 years ago, that there is a biological clock, and that biological clock is very important.
Yeah.
So that's still the traditional teaching, but I think the lines are blurred a little bit in today's clinical practice.
Right. You touched upon a few things, people waiting, maybe establishing themselves first, finding a partner, or just having financial security. But what other factors go into infertility issues? Is it just because they're waiting longer, or you see more of a population that's related to disease, or maybe someone who has tested positive for a genetic?
All of the above. It's I could cast a very wide net as to what that encompasses. I would say that primarily the main cause of infertility is age.
Okay.
Both for male and for female. Okay. Obviously, for females, the reproductive aging occurs earlier than it does in the male, unfortunately.
Right.
But it's certainly age. There are other things that go with the aging process separate from that. For example, things like endometriosis have a more significant impact if you're 35 and have had
Right.
endometriosis your entire life, as opposed to being 20, as the same way that if you smoked for 15 or 20 years, but nobody smokes anymore.
Right,
Very
right.
few people smoke, but just the example that I always give
Right.
has a more pronounced effect than if you smoked for 3 years when you're in high school and have your first kid at 21.
Right. Got it.
So it's cumulative,
Yeah.
essentially.
Got it. Dr. Karsenti, when you're talking about your population too, do you find that there's an increase in fertility issues with your patient population?
I mean, yes and no. I mean, I think there's a lot of women who, I wouldn't say they're misinformed, but they're like, oh, well, my friend got pregnant in their late 30s, didn't have a problem, so I'll be fine. There's definitely a population of that. And I talk to them about fertility and how it goes down after your late 20s and try to provide education, because the last thing I want is for a patient to kind of arrive in her late 30s and then be like, I'm
I didn't
having
know.
difficulty, and then say, oh my God, I wish I had known. So I feel like my job is to talk about that and educate them so they know their options. I think that's one thing. And then I also think there is a subset of patients also who are just generally unhealthy.
Right.
Like, I think there's a lot of women in Miami, I mean, who take care of themselves and are exercising and, you know, all the things. But there's other people who still are just not in that healthy lifestyle. They have hormonal imbalances, you know, and we try to work on that. But I think I still see a fair amount of that in my practice. People who just aren't taking care of themselves, and then they wonder why they can't get pregnant.
So is there something that if someone's trying to get pregnant or thinking about getting pregnant that you could tell them to do to increase their fertility health? Like what to plan beforehand, what you should be doing? Are there extra vitamins? Are there, like, what do you advise them to do?
I mean, I try to address healthy lifestyle all the time with my patients. And that's really, I think, number one is minimizing processed foods. I think they're probably in the space of infertility, there probably is some kind of environmental factors that contribute to endometriosis and all the hormonal imbalances that we see. I think our foods are not the same foods that they were 20 years ago.
Oh, yeah, no. My kids are in their early 30s and or around 30. And the only thing we were told was make sure you get folic acid. That was the advice.
Right. Which is still really
Which
important.
is still important, but
Right.
nobody ever thought about environmental things or the processed foods that we were eating or anything else that we were taking in.
So I try to talk to my patients about healthy lifestyle, healthy eating, exercising, a good multivitamin, something with folic acid, like you said. And then, you know, sometimes we'll talk about the environmental factors, you know, like cutting back on the plastics, you know, just being aware of what they're putting in their body and their partner, what their partner's putting in their body too.
Right. And what they're exposed to too, where they go and what they do.
Yeah.
I don't know the statistics on this, but what is the size of the population that's experiencing fertility issues? And how does that compare to the percentage in your practice that you're seeing?
So infertility affects 1 in 6 couples.
Okay.
I would tell you that it probably affected less couples 30 years ago or 40, 50 years ago, the baby boomers.
Right.
But that's because they were having kids at 20.
Right.
So we don't really have great statistics. And remember that infertility and IVF is really pretty new.
Right.
I think the more people wait, the more difficulty they will have. There's absolutely, as Rebecca said, so many different factors that are involved. You know, PFAS, forever chemicals, leaching from water bottles, all of these things that we're taking into account for longevity, which has a lot of overlap with infertility and general health.
Yeah.
Age still seems to be the predominant factor that affects everything. But you know, the biggest factor that we see when we say aging is what's called premature ovarian insufficiency or diminished ovarian reserve, which is kind of an old moniker. And there's 13 reasons why this happens: cocaine use, alcohol abuse, smoking, secondhand smoking, radiation, chemotherapy, autoimmune disorders, infectious disorders, which doesn't happen
Right.
in first world countries, genetic disorders, spontaneous and or familial, and then idiopathic. Endometriosis, surgery to one or both ovaries,
Right.
and idiopathic, which means
Right. We don't know where it comes from.
And we think either you were born with less eggs, you consume them faster in isolation or in conjunction with any one of the other 12 that I just mentioned.
Right.
And in my world, like an oncologist sees every woman as cancer, and I see every woman as infertile.
Infertile. Yeah.
And Rebecca sees 45-year-olds get pregnant, and
Whoopsie.
right. And so their perspective is different. The lens they're looking at things are different. But I see 25-year-olds in menopause and 30-year-olds in menopause, and I see men who are 30 with azoospermia, no sperm, because they were doing testosterone for 10 years and they burned their testicles out.
Oof.
So
it's a lot.
It's varied.
It's very varied.
Yeah.
And also the combination of all of those factors. Okay. So when you talked about different ages and different things, I hear a lot of discussion among women, particularly young women in their 20s and 30s, about egg retrieval. And they talk about the many factors that go into wanting or needing to do egg retrieval. They may be concerned about their age and the amount of egg reproduction, which is production, which we just talked about. And some are just not ready for children yet, either emotionally or economically or for whatever the reasons. But they want to secure the possibility of carrying a child or children in the future. Some may be positive for genetic issues and need to remove their ovaries. So they too want to secure the possibility for future pregnancies. What factors go into the decision to do egg retrieval? Or what are you seeing besides these contributing factors as the point that they have this discussion with you and say, okay, or when do you say to your patients, this is something you should consider egg retrieval?
I mean, as my patients between, I would say like 30 and 35, when I see a single patient who is not thinking at this time that she's ready to get pregnant, I'll address it. We'll talk about it. And as they kind of creep closer to 35, I say, okay, well, what are your plans? Do you want to have children in the future? Is this something that you would regret if it doesn't happen? And then when they say that they want kids and it doesn't seem to be on the horizon, I do encourage them to see doctors like Dr. Hernandez-Rey, because I think, and I always say to patients, it's information.
Right.
I think it's great to be educated.
Yes.
And like that's the great thing about doing a podcast like this. It's that I think women just need to educate themselves. And I always say, you're not committing, you're not putting the money down
but
to
the
necessarily
knowledge.
do the egg freezing, but learn about it, learn about the process, learn about what it would look like, and also from a cost perspective, because thankfully we are seeing some insurance coverages, not so much in Florida, but in other states. So maybe as things evolve and there's better coverage, even if you learn about the process now and then you're not ready now, maybe you'll be ready in a year. Maybe you'll be ready
but
in
the
2
knowledge and
years.
information about that.
Yeah, I think it's important to be educated.
Dr. Hernandez-Rey, can you break down what IVF entails, like the whole process?
Yeah, sure.
Like what do your patients have to do beforehand to prepare and how all of that?
Well, I think egg freezing, right? You wanted to talk about
all
what the
of
process
it.
of egg freezing is?
Well,
or?
all of it, because I mean, there's the process of egg retrieval. You'd have to tell your patients that they're going to be boosting up with shots to increase egg production. And then you'd have to tell them there's options afterwards, right? So when you're doing egg retrieval, my understanding is that you could either freeze the eggs or you could fertilize the eggs and implant them. But I've also heard discussion about freezing embryos.
Mm-hmm.
Okay, so can you break down everything for us?
Yeah, sure. So essentially, IVF as a whole is 4 phases. Obviously, before those 4 phases begin, which is the therapeutic aspect of this, is there's an evaluation portion,
Right.
which generally is predicated on the cycle of a woman, where we do things like cycle day 3 labs, cycle day 2, 3, 4 labs, which are baseline laboratory that assess a woman's ovarian reserve.
Okay.
As you know, women are born with a finite number of eggs, and the consumption of those eggs, however it happens, of 13 ways that I just mentioned, it happens, and that's what we're trying to assess including a hormone called an anti-Mullerian hormone, which has gotten a lot of notoriety because it's basically probably the most sensitive marker that we can use. It's certainly not perfect.
Right. It's a gauge.
It's a gauge. And then we do a uterine assessment, which is either a hysterosalpingogram, which checks fallopian tubes or the uterus, or a hysteroscopy or saline sonogram to look at the
lining,
the contour of the uterus itself, more than just the lining. And then obviously the male is involved, and we do a semen analysis, which we're like amoebas. We can do this at any time. Single-celled organisms, while these women are very complex.
Right.
A lot of things that we're monitoring, including an entire hormonal panel for assessment of hormonal imbalances, as Rebecca or Dr. Karsenti spoke about, which generally when we talk about in this world today, it's either polycystic ovaries or perimenopause.
Right.
Essentially. Prolactin, thyroid, all of those things are.
Do you see a lot of PCOS?
Sure. Yeah. Especially in this population here in South Florida. But generally the numbers are about a third of the patients who are seeking infertility care. I would say we're probably about a fourth.
Okay.
Sorry, not a fourth, but not 33%, but 45%.
Oh, so even bigger population.
Even bigger. Got it. Yes. That's what I meant. I'm sorry.
No worries.
And then we begin the IVF portion, if that's the route that they want to take, and that also incorporates the egg freezing or the fertility preservation portion. But essentially, we're talking about 4 phases. The first phase is the preparation phase, which generally is some sort of hormonal manipulation that severs the connection between the pituitary and the ovary, which allows us to be able to control the stimulation portion, optimize it, maximize the results. During the second phase, which is the stimulation, where women are injecting themselves on a daily basis for the most part for
how long?
Generally 10 to 12 days, and that will culminate eventually after very intense monitoring with blood work and ultrasound to get to the extraction or the egg retrieval or the harvesting, which is a minor surgical procedure under anesthesia with an anesthesiologist. They generally don't feel a thing during the procedure. They're asleep.
How many eggs are you able to retrieve?
Well, that depends. It depends on the age, the women's ovarian reserve, the stimulation protocol that's chosen. Like everything in life, too little is too little and too much is too much.
Right.
There's a sweet spot that, for the most part, we say anywhere between 12 and 16 eggs should be reasonable. And then that's begins the fertilization process. If we're moving on to in vitro fertilization. If we're freezing eggs, we freeze eggs right there. We freeze not the total number, but the mature number of eggs, which means that they've gone through the meiotic processes that constitute the maturation of an egg, which can then be fertilized to complete the maturation of that egg.
Got it.
The limitation with egg freezing.
How long can they be stored?
Indefinitely, in perpetuity.
Wow.
The limitation of an egg, and this is a very sensitive topic for women who are moving on or have decided to freeze their eggs, is a couple of things. Number one, we can't stick a probe in it and say it's a good egg or a bad egg.
Right.
Number one. Number two, with the aging process, there's a lot of intercycle variability. And so when a woman is 18, 11 out of the 12 months of the year, it's a perfect egg and they have a 3% chance of miscarriage. When a woman is 40, there's only 1 or 2 out of the 12 months that are good eggs.
Yeah.
And when they're 18, they'll recruit 1,000 eggs and 950 are good and 50 are bad. By the way, I'm just making these numbers up.
No, I get it.
And when they're 40, it's 100 eggs, of which 90 are bad and 10 are good.
Right.
So in today's world, they're stuck in this very nebulous zone where there's more information out there. They're more in control. Women are empowered. But any woman who sits in front of my office, I think it took a lot to get there.
Yeah.
Because that's not what they planned for themselves. This generation still believes that they have this lofty goals of, being together, having kids, all of that. For the most part, obviously there's exceptions with everything. And so when I can't deliver what they expect, which everybody expects nothing but absolute
100% perfect results.
Perfect results. That's where the communication comes into play. And so you have Instagrammers now who are infertility specialists who are actually telling, and I've received multiple calls from friends who have daughters roughly in their college years who are like, I just saw this woman, for example, and no critique.
Right.
I'm just stating the facts, I just saw this woman and she's an infertility specialist and she's saying that she's going to freeze her daughter's eggs at 22. And she's not wrong. You know, biologically speaking, she's
right.
not wrong. Now, if I tell Rebecca, who's an OBGYN, an incredibly gifted and talented woman, that I'm going to recommend to her daughter
right.
to freeze her eggs, you're absolutely nuts, right? And that's where the problem comes, because
right.
then you have a 34-year-old woman she's having that perfectly sane conversation. Take your time, go and have a conversation. But if her AMH is 0.3, she's like, well, why didn't I do this earlier?
Yeah, why didn't I? I think that's why I hear a lot of 20-somethings and early 30-somethings discussing, I want to do this now, even before they have like a significant other in their life, just to ensure the possibility of having children.
The same way if I tell a 39-year-old, Rebecca sends me a patient, let's say, and she's 39, she has no children, and I have a conversation about IVF, she'll go back to Rebecca and she said, what? He said, what? Why IVF? And she'd be totally right. She's like, why would I be talking about IVF at 39?
Right.
Well, the practical standpoint is that most couples want more than one kid. And at 39, if she's been trying or just starting to try, who knows, if we don't have a crystal ball, how long it's going to take.
Right.
And by the time she's ready to be mother again, it may be too late.
Right.
And so that's the only way that we can
ensure.
Well, not ensure, but do the best we can to preserve the fertility now as opposed to later. Because yesterday is better than today and today is better than tomorrow.
Right. Got it.
And I think it's interesting to note too that measuring the AMH for fertility, or like as a proactive measure.
Will you tell our listeners what AMH is?
That's the anti-Mullerian hormone that he referred to, which is part of our testing that we do as part of the infertility workup, because AMH was not created, but was discovered and utilized for the IVF process, and to see which patients they think would do well or have a good outcome with multiple eggs or a live birth. The AMH was developed for that purpose, and not for what we are using it today, which is I get asked all the time, younger 20s, can you measure my fertility? I want to do the fertility test. And there's a lot of companies now who are doing this and offering this test online, that patients can do a fertility test, which is the AMH, in a vacuum. But the American College of OBGYN and the Menopause Society actually says we shouldn't be doing that. I don't know
Why?
if you have an opinion about that.
I do.
I do it.
I don't agree.
Right. I actually do. Right. I don't agree either. I measured for my patients for exactly the reason that Armando referred to and you said, because if you're thinking about your fertility and you're 24 and you want an idea, then let's check it.
Why not?
But I think doing it online in a vacuum is not the right way to do it. I think it should be done
with your doctor,
with someone who's educated and who can give the appropriate counseling.
Right.
Because it's not a perfect test. It can give us an idea of what's going on, but it doesn't tell us the whole story. I'm sure I've sent patients with a low AMH to Armando saying, okay, I think you should go see the specialist. And maybe they didn't have a problem, and vice versa. So I think, it is a nebulous time, and it's a difficult subject, because we want to try to capture these patients when they're fertile, but at the same time I agree, egg freezing at the age of 22 doesn't necessarily sound correct either.
Well, I mean, it's invasive and all of that.
Right.
And how many 22-year-olds are thinking about it too at that time? Not many.
But
no?
Like we're planning for a kid's college nowadays, where my parents just said, here's a number 2 pencil and take your SAT.
Right.
Well, the same thing is happening with the infertility, because it's very prevalent in the media.
Right.
And again, biologically speaking, they're not wrong.
Yeah.
But nothing is perfect. Nothing is binary.
Right.
And women, as I said, and I wasn't joking, women are very complex.
Yes.
And one semen analysis, we know if a man is fertile or infertile.
Right.
With women, it's not just the AMH. It's an AMH. It's an ultrasound that says ovarian volumes or antral follicle counts. So it's an amalgamation of all these different aspects of the fertility process. But I don't agree with the American College of OBGYN, because the same way that I said the American College is, as I used to be
Right.
a fellow of the American College as when I was a fellow, and their lens is different.
Yeah.
And menopause, I agree with the Menopause Society, which shouldn't be used to predict menopause either, or perimenopause.
Right.
But in my world, if you have a 28-year-old who has an AMH of 0.8, and I see it all the time, then we should act.
Yeah.
Let's get going. Yeah.
Right. We should act. So in that way, it is an important marker to be taken into consideration.
Do you discuss this with all your patients, no matter their age?
I do.
Okay.
Yeah.
Yeah. And there's got to be other factors for screening too. On an emotional level, psychological level. Do your patients go through that?
Yes, definitely. And I think when I say that I discuss it, I mean, it depends on the patient and where she is, and also in her life cycle.
Right.
You know, there are 22-year-olds that are ready to talk about, you know, maybe they're exploring couples or, moving in that direction. And then there's very young 22-year-olds. And same thing in their late 30s.
Same thing with the 30s.
Yeah.
Right.
And it's also what's going on with their lives professionally and kind of where they're headed. And
Right. All of those factors go into it.
yeah. But education is super important.
I think so too. And I've heard a lot about not just personal decisions for doing it, but I've heard a lot of people who have medical issues or have tested positive for different diseases or genetic things, and for preventative measures have removed their ovaries. And so they want to have the opportunity to have children in the future later. I know very little about your lab, but I've heard amazing things. Can you tell us about your lab and your success rate?
Yeah, sure. Well, I'm a big believer in surrounding myself with smarter people than I am. And so, I mean, we started our lab about 13, 14 years ago. Actually, our lab director, who's in town right now, her name is Sangeeta Jindal, and she's a past president of Society for Assisted Reproductive Technologies. So it's extremely well known. She's the one that helped me build the lab and create the protocols that were necessary to create our success, humbly speaking, but proudly, honestly, and these are publicly available stats. Like, we are very close to the top in the country.
Amazing.
We fly 2 embryologists from out of state because they're that good. And there's with private equity involved very much in our space, in the infertility space. There's been an incredible growth of practices.
Wow.
And when I was a fellow, when I first started in private practice here in South Florida, we were basically 3 practices, and now there's over 8, 9 practices.
Wow.
So I think doing things right, keeping your head down, and don't worry about anybody else is what's key. And so, great embryologist, a great lab director. And also, we installed LifeAir, which is
tell me about a little bit more about that.
LifeAir is I wish I had any financial interest in it. Unfortunately, I do not. But basically, it's a ultra purification system where it removes the VOCs, or volatile organic compounds, that are in the atmosphere, basically reducing it to 0.00001. Because of the sensitivity of embryos, eggs, and sperm. Right. Particularly eggs and embryos are more sensitive to the atmosphere. And so, we have a no perfume policy, no deodorant policy, no fragrance policy. And literally, if you come in with any fragrance, we do a Zoom call or we reschedule you. Okay. That's how strict we are. And it's a pain for patients because I don't use perfume, cologne or anything usually, but I can see how
It
it's part of
affects-
your
yeah.
it's part of your daily routine,
Sure.
and it happens. But if it were your embryos, you wouldn't want
No.
anybody screwing up
Messing
your
with
embryo.
it. No.
So I think we go the extra step. I don't pretend to be better than anybody else. I think we are obsessive compulsive about those things, but so are other infertility specialists. Again,
I think you'd have to be
just doing,
just to make sure
the
the integrity of all of it stays.
building multiple layers to try to produce the best results possible. Because as good as we are, pregnancy rates are not great.
Yeah.
And so if you went to your plastic surgeon and said, and he tells you that you're going to have a 70% chance of liking the results of your breast augmentation, or you probably wouldn't do it, right? Well, this is the best we've gotten, is 70%. With our donor egg program, we're very successful, mid 80s, but still 15% that don't get pregnant.
Yeah.
And primarily that's beyond that is because there's three aspects to a pregnancy, which a lot of people, sometimes forget, which is there's egg, sperm, and embryo, which is one unit,
Right.
but then there's the uterus, and then there's any external factors, whether it's obesity or the PFAS chemicals that you're surrounded with,
Right.
firefighters as one occupational hazard where they're involved with incredible toxins in
Right, in the environment.
in the environment.
Yeah.
Or you're obese or diabetic or hypertensive, or you have some autoimmune complex that can affect you keeping a pregnancy. So
That's a lot of factors.
multifactorial.
I hear sometimes that after people have done IVF, they get pregnant on their own without it. Is that a fairy tale? Does it happen? Do you have a percentage of people?
What do you think, Rebecca?
I don't think it's a fairy tale. I see it all the time.
You do?
And probably because there's probably some factor of anxiety that goes into, especially with the first pregnancy, seeking
Oh.
a first pregnancy,
Stress
and all
is a
the
huge killer of
anxiety
everything.
and the stress, and and I often, even before they get to Armando, will say, "Oh, you've been trying for more than 6 months. Are you using ovulation kits? Yes, I'm doing this. Okay. Well, maybe you guys should take a vacation."
Right.
And relax and just have fun. And sometimes they get pregnant.
Yeah.
So I think there is, which is hard to tell people, just relax.
Yeah.
But there is definitely,
When they're focused, hyper-focused on a goal.
Yeah, there's definitely that little something that sometimes when they're not looking for it, hey, here it comes.
It happens.
Yeah.
In the egg retrieval process, does it cause epigenetic changes or changes to gene activity that become inherited? Or what are the risks?
That's a loaded question.
I'm sorry.
No, it's okay. I love a challenge.
I want to know it all.
So the answer is we don't really know.
Okay.
It must not, because we have perfectly normal children that
Healthy
are born
babies,
from IVF. There are circumstances where we think we do, which
Mhm.
is what's called a hyperstimulation,
Right.
where you have a patient who, as I said to you, the sweet spot is 12 to 16, right?
Right.
But you have patients who are overstimulated just because inherently there's something, like a patient with polycystic ovaries,
Right.
or the clinician will overstimulate for
Mhm.
whatever reason. That's something that happens very often in Latin America. Again, not a criticism, just an observation. And so we definitely see that there's a larger attrition when you have,
No, that's okay.
39 eggs.
Right.
You go from 39 eggs in a young woman to 3 embryos. Well, that doesn't really happen
Yeah.
unless there's something that you've done to cook the eggs, as they say. And the
Right.
best example that we have of this is 10 years ago when these egg banks started popping up. If you and I started a business together, well, what do? We'd take a young woman and stimulate her ovaries like she was 40, just because more bang for your buck, right?
Right.
A 22-year-old, you stimulate her like she's 35, you get 100 eggs. Well, now that's at least 10 couples, as opposed to doing the right way and getting 2 couples out of
Right.
2 sales. And the pregnancy rates were abysmally poor. And they had to sort of pivot to
Yeah.
what was actually as close to physiologic as possible. Because what we're trying to achieve with IVF is a super physiologic approach. But again, like everything in life, extremes are bad.
Right.
So those are the epigenetic changes that we think occur.
Okay.
But also pregnancies that from IVF often require more monitoring because there could be more complications, different birth rate, cardiac issues. So often those pregnancies are monitored just because.
Is that because of age or because of IVF or
probably both? Yeah.
Okay.
Yeah.
All right. And we touched upon the emotional aspect of this a little bit, but what are the emotional, physical, and financial? Because you said a little bit about insurance, tolls, egg retrieval takes.
I mean, I think a lot of it depends on insurance coverage. If there are companies that are covering egg freezing for their employees, which is amazing. And I think from a psychological perspective, I mean, I think I start the conversation, or they might start the conversation, but we have the conversation about their plans as far as the future and children and when that will be, where they're going to be. And so I think that moment to me is quite a psychological journey.
Yeah.
And Armando referred to that too, that by the time they get in front of him, they've done a lot of soul searching and are really trying to figure out what to be doing. And, I think, I don't know if you have in your practice a protocol for patients to do any therapy or if you have a counselor in your office.
We have.
Oh,
there's
brilliant.
counselors that we work with for sure.
Is it just for screening purposes beforehand or throughout the process?
A lot of people are different. I think they're nowadays are more open to the concept of sitting in front of somebody.
Right.
Certainly you get a lot more pushback from the male than you do the female. At the end of the day, you're paying a lot of money for the possibility of something happening. And so the anxiety that's created is the unknown.
Through the roof,
like what's
sure.
what's going to happen?
Yeah.
Which is awful for couples. Thankfully, just because I'm knee deep in it, thankfully there is a lot more insurance penetration in South Florida now.
Right.
I mean,
I was just going to ask you about that, about the accessibility and the affordability of fertility
everything
insurance.
The problem with fertility and insurance coverage is that it's potentially two ships going in opposite directions.
Right.
And I'm sorry, I keep hitting this.
That's okay.
The problem is that technology is growing so quickly, and we're completely powerless because these companies are charging a lot of money for this new technology, which then should increase your pregnancy rates. But the insurance is another behemoth that wants to make money.
Right.
I mean, they're not. Everybody's in the business of making money, right, for themselves. So reimbursements are less. So then practices, and this is global.
Okay.
Don't have the means for not research and development, but just development.
Right.
To get the better scopes, the better, particularly the smaller practices. And then you have the private equity part, which they're all about cost cutting. So they run very lean. So then you have the customer service aspects, which are completely decimated. And if anybody needs customer service, everybody needs customer service.
Right.
But a lot of hand holding is infertility patients.
Yeah.
So we're kind of in a difficult situation right now with regards to infertility, and I think the dust will eventually settle, and good always wins over evil.
Yes, it has to.
But it's very difficult. And I'm sorry to be so verbose, but
no, I love it.
The accessibility is much better. I would say 10 years ago it was about 15% insurance. Now I think we're closer to 50%.
Oh, no, that's great. I didn't even think you were going to say it was that high.
Yeah, it's about 45 to 50%.
And I'm sending you a lot more patients.
Great.
Yeah.
What do your patients say is the most difficult thing for them? Is it the cost? Is it time? Is it money? Is it the emotional toll? Do you have the discussion with your patients or you?
I mean, I do, I guess, because I'm sending them often his way. I mean, plenty of people go his way without me.
But what are they saying to you as patients? They're saying, what is the most difficult thing?
I mean, we talk about what the process entails and that often there is a cost.
Right.
If there is insurance coverage or not. And also it is a big time commitment. And a physical commitment.
Right.
I just had a conversation with somebody this week about possibly pursuing egg freezing. And I said, there's a lot of different offices in the city. And, this is my favorite, of course. But if you live in this part of town, you have to make sure, are you willing to drive to Coral Gables every day? Because often you're getting blood work, ultrasound every day. So, just to manage expectations and have them know
I think that's
that
good. Manage expectations.
It is a commitment.
But they don't come back to you and say the most difficult thing is.
I think the most difficult thing is doing the process and the unknown of what's going to happen.
Yeah, well, that's a big fear.
Right, whether it be IVF and hoping for a baby in a short period, or the process of egg freezing and having those eggs stored for when you're ready, and then the unknown that I don't really address, but that unknown of what their future is going to be, what their partner is going to be, and all that.
It's a lot.
It's a lot.
Is there anything you wish my listeners knew about the egg retrieval process that maybe they might be misinformed about? Because we touched about a lot of misinformation things, but is there anything else we left out, or anything else you think?
Yeah, I mean, the most important thing is that there's a lot of intercycle variability, and your ovarian reserve may be normal or age appropriate,
right?
But on any one given cycle, we may hit it out of the park, and on any given cycle, we may not.
Right.
And again, I have never seen one woman who doesn't expect anything but success,
right?
And getting the optimal number, that sweet spot on one given cycle.
One go, yeah.
And that's really a challenge because, as I said, I think there's no woman that I've met thus far that's said when she was 18 or 20 or whatever, number one, I have to egg freeze my eggs. And number two, that when I do it, I may not get, and I may need a second cycle, or they may not work. I mean, I always tell them, like, this is only insurance policy. The goal is for you to conceive naturally, and just to feel more comfortable, less anxious about, oh my God, am I aging?
Yeah.
But, we've had situations where, unfortunately, the eggs didn't survive or didn't lead to a viable pregnancy.
Crushing.
And also that every woman is different.
Yes.
I think that, there's so many people say, oh, well, my friend, my sister, my cousin, had
That's
this
not you and your body.
Or even your mother, or your sister. I think even a close relative, their experience is not necessarily yours because we are all so individual. And as Armando put, we're complex creatures. Women are beautiful, complex creatures.
Yes.
And so much goes into that egg that's going to then go and be fertilized for a baby. It's had a whole life. That egg has lived a whole life from when you were inside your mother's belly. And so everybody is so different.
Yeah.
And for good or for bad. Right. But I always try to have people feel reassured and positive. And yes, there's so much talk on the media about infertility.
But what I think you said, information is key.
Yeah, and get educated. And if you're interested in doing testing with your OBGYN, ask your OBGYN to do it. Some might say no and say, oh, no, it's not recommended. But many will say yes. And I think it's good to be educated and knowledge is power. Yeah.
Oh, 100%. Yeah. And what's the future of IVF? Because I've heard some things about AI.
There's a lot of AI. It's not where it needs to be. Although if you speak to the companies, they'll tell you that it's there. It's not there yet, but certainly things like prediction models for assessing the best quality embryos. That's in the pipeline.
That's cool.
Number one. Number two, standardization of protocols. I'm not clear as to what benefit that there is in that, but I mean, KPIs and data analysis is always essential. I mean,
Yeah.
I see 3 Excel spreadsheets a day, literally, about our KPIs, about whether it's patients or protocols or success rates or lack thereof.
Right.
So I think data is important. I think what's more in the pipeline is it's going to be relevant is automation
Wow.
of the embryo lab. We have Conceivable is a company.
Automation?
Yeah, like
Wow.
elimination essentially of an embryologist. It can do essentially what an embryologist does, and they've already done it in Mexico.
Wow.
Yeah, and then I think in the world of the area of genetics, and I'm not talking about designer babies,
Right.
and it's a very toxic word, but design can mean a lot of things, and editing certain genetic mutations that are not necessarily incompatible with life, but compatible with a horrible life.
Right.
And if it's okay to fix a heart valve in utero or a ureter, then why is it not okay to fix a gene that could mean a reasonable quality of life for that
Right.
human being? So
Sure.
again, I'm not making any judgments here. I'm just
Right.
putting it out
Stating
there,
facts.
for comparison. So I think that's very much on the horizon.
Wow. Is there anything you think we left out? Covering? No?
I think
We covered a lot.
I think we
Yeah.
covered a
We
lot.
covered a lot.
Yeah.
Well, I can't thank you both enough for being here today. This was beyond incredible and informative, and I really appreciate it. I hope our listeners have gained great insight on their reproductive options and how lucky are your patients. Really amazing. Listener links, I'll be adding them all to everything that I post, so you can give me all those informations. I do one thing at the end of my podcast before I sign off with my guests. You game? It's called Quickie Questions.
Sure.
Okay. And they're just short little fun things. What are you most proud of?
My kids.
God, you beat me to it.
Sorry.
You can say the same. Your kids.
Yeah, my kids.
Yeah, of course.
Absolutely.
Okay. What inspires you?
So many things. I think little things every day. I love looking at the moon at night.
Yeah.
The full moon this week. Walking the dog last night, looking up at the moon, always reminds me of, when I was delivering babies and I'd see the full moon and it was going to be a busier night on the labor floor. So,
Really?
Yeah.
Oh, God. Well, now that I look at the moon every night, I'll be thinking differently about what the full moon means.
Yeah.
And what about you?
So many things, honestly. I mean, you can gain inspiration from the moon or anything that surrounds you. My job, I love my job. I really love what I do. I love my family. I love my kids, my friends. I'm surrounded by incredible friends.
That's wonderful.
My life, everything is a reason for getting up in the morning and making it a better day than it was the day before.
Yeah, it's blessed. When was the last time you really laughed hard?
I was laughing pretty hard. I'm trying to remember. My perimenopausal brain doesn't remember.
It's okay.
But I was watching a movie with my kids, and we were all like crying, laughing.
I love that.
And, yeah.
This
But I don't
weekend,
remember which one.
Yeah.
this weekend, my kids and my wife were making fun of me for something that I totally cringed at.
Cringe
I said,
dad.
and I'm totally fine with making fun of laughing at myself.
Yeah.
So
That's good.
I laughed crazy. I don't remember what it was exactly, but it was something like out of the 80s, like really weird movie. And I said it
Like a good John Hughes quote or something.
probably.
Yeah.
And they were like roll their eyes. and
Yeah,
like,
of course.
Dude, seriously.
Yeah.
Bro.
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 Exactly. Right.
Come on.
All right. So you give so much to your patients gift wise. What is the greatest gift that you've gotten from your profession?
I'm going to say this one first.
Yeah,
Okay,
please.
go ahead.
Satisfaction. I mean,
Yeah.
honestly,
Yeah.
I was in
I can only
an
imagine.
I was on an airplane on couple weeks ago from New York, and there was 3 kids that I had on that flight at 11 o'clock at night that I had helped bring into this world.
Oh,
and one of them,
amazing.
it's like 11 o'clock. The flight is delayed. The lights have been turned off. So like whoever wants to sleep while we're waiting on the tarmac to push off. And the kid says to me as he's walking to his seat, he's like, "Hey, my mom said you made me." And everybody woke up and laughed. So I mean,
that's so beautiful.
it's amazing.
Yeah, that's beyond.
Yeah.
Yeah. Actually, so, because I could say the babies I delivered, but I love, because I am in the legacy of my dad.
Yeah.
I happen to love when I see his patients now that he retired, and I see them in my office, and I say, your dad is such an incredible man.
The continuity.
And it makes me feel good every time.
Proud,
That's really
man, for sure.
awesome.
You should be. He's a great guy. He's a great guy.
Yeah. Oh, well, thank you guys again. I really appreciate you being here. It really was an education, and I'm honored to have you both.
No, thank you for the invitation. That was very nice, and I appreciate
I'm
the time.
thrilled. Oh, I appreciate the time too. To our listeners, thank you so much. So grateful you're here. Keep listening, keep learning, keep laughing, keep up with Beek on Being, and stay well, everyone. Listen to Beek on Being wherever you get your podcast. All episodes are automatically transcribed. A big shout out and a huge thank you to Stephen Chen at Penthouse Studios.
Woohoo.
Thank you.
Awesome.
We good? Thank you guys. This was amazing.
That was great. Yeah,
I hope you had fun
awesome.
too.
Yeah. I learned a lot.
I can't